Hello everyone here. Welcome back to Dr. Han's Pharmacy Classroom Pro. Now in this video we are going to have a quick review of the topic glaucoma. We'll look at pathophysiology very briefly and we'll focus on drug classes that can be used to treat glaucoma and its mechanisms of action. Glaucoma is an ocular disorder involving optic neuropathy or nerve loss and is characterized by changes in the optic nerve head and loss of visual sensitivity and field due to high intraocular pressure. Now, what contributes to the intraocular pressure is the aqueous humor, which is a transparent fluid contained in the anterior and posterior portion of the eye, and it is formed in the ciliary body via filtration and secretion. Now, this aqueous humor contributes to intraocular pressure, which is the pressure created from the constant inflow and outflow of the aqueous humor. Normally, aqueous humor circulates in the eye, but when the drainage canal is blocked, it stays in the eye and increasing the pressure inside the eye and damaging blood vessels and optic nerve, and eventually generating progressive vision loss and blindness if it is not treated. So how does it drain? Aqueous humor is drained through the angle of the anterior chamber through the trabecular network into the Schlemm's canal. The impaired drainage will lead to increase in intraocular pressure that eventually can lead to glaucoma. Now, however, there are two types of glaucoma. The first type is the open angle or the slow onset, which is the more common form that we treat. Now, the angle of the anterior chamber in this case is normal. However, the drainage of the aqueous humor is still impaired because of changes in the spongy tissue of the trabecular network or the Schlemm's canal. Now, this can also happen by blockade of foreign bodies. Another type of glaucoma is called closed angle or narrow angle glaucoma, which is an acute onset of glaucoma. It is usually happened by the blockade of angle by the root of the iris, just like sympathomimetics and anticholinergics, which can dilate the pupils, carry a slight risk of precipitating acute attacks of narrow angle glaucoma in susceptible individuals. So we know that glaucoma is because of abnormal or high intraocular pressure, and this pressure is contributed or coming from the aqueous humor. So to treat glaucoma, the goal is to restore the normal intraocular pressure. So we can either treat it by increasing the aqueous humor drainage and or decrease aqueous humor production. So here are the drug classes or agents that can be used to treat glaucoma. Really, we are talking about either drainage or productions, and sometimes both. So we have drug classes like the prostaglandin F2 analogs, beta blockers, carbonic anhydrase inhibitors, a combination of agents, alpha agonist, cholinergics, either like cholinergic agonist or cholinesterase inhibitors. And lastly, we have a newer class of agent called a rho kinase norepinephrine plasma membrane transport protein dual inhibitor, which also enhances drainage. Now, in this lecture, we're not going to talk about individuals, but we will focus on drug classes. First, we have prostaglandin F2 analogs. Now, these agents look like the PGF2. And their mechanism is to increase drainage of the intraocular fluid through an alternate route, which is called accessory uveosacral pathway. It can also relax ciliary muscles and increase outflow of the aqueous humor. And on top of that, it can also degrade extracellular matrix materials that are blocking the outflow through the trabecular network or the canal of Schlemm. The second class of drug here is beta blockers. Now, remember, here we need to focus on the production side of the story. Now, these aqueous humors are secreted by the ciliary bodies, and ciliary bodies has beta adrenergic receptors and mostly beta 2 receptors. And these receptors, by stimulating beta receptors on these bodies, it will stimulate secretion. So they are responsible for aqueous humor production. So if stimulating beta receptors can enhance productions, to decrease productions, we will use beta blockers. Now they are used to decrease productions of intraocular fluid and aqueous humor, and blockade of beta adrenergic receptors decrease adenylate cyclase activities and further decrease cyclic AMP formation and decrease cyclic AMP dependent PK activities, and ultimately lead to the decrease in the productions of aqueous humor. Now we can also use carbonic anhydrase inhibitors to decrease the productions of intraocular fluid. Now, the name tells you these drugs inhibit the carbonic anhydrase isozyme 2 found in the ciliary epitheliums. Now, it is worked by decreasing the formations of bicarbonate ions, and bicarbonate anions are required in order for the epithelial cells to secrete sodium. And sodium secretion is also necessary for the formations of aqueous humor. So by inhibiting bicarbonate, you're stopping the sodium, and you're stopping the sodium secretion, you're stopping the fluid that which follows the sodium. So ultimately, you decrease the formation or productions of these intraocular fluid. Now the next class here is alpha agonist, and more specifically, it's a selective alpha 2 agonist. Now, alpha 2 adrenergic receptors are also located on the ciliary bodies, and stimulations of these receptors can inhibit the secretions of the fluid. So what happens is when you use these selective alpha 2 agonists, it will decrease the productions of intraocular fluid or aqueous humor. Now, notice that we have two different positions where we can find alpha 2 receptors. First is the presynaptic alpha 2 receptors. Now let's look at that first. By activating the presynaptic alpha 2 adrenergic receptors, it will decrease the release of sympathetic nervous neurotransmitters such as norepinephrine. And by decreasing norepinephrine, you will decrease stimulations in the beta-mediated productions of intraocular fluid. And the story doesn't stop here. Its action also happens on the postsynaptic alpha 2 adrenergic receptors, and by activating these receptors, it will actually opposes the actions of the beta receptors, and therefore decreasing the productions of aqueous humors. Now, these agents also have activities to enhance uveosacral outflow. Now, sometimes we could argue using non-selective adrenergic receptor agonist. Overall, it will increase drainage, which by non-selective sympathomimetics. Now, however, because they are non-selective, they have an effect on all adrenergic receptors. However, overall, the balance, it will enhance the uveosacral outflow and also the conventional outflow, such as using epinephrine. However, these drugs are poorly tolerated, and clinically they are not used so much anymore, and we have better options. Here I present as just for the completeness of information. Next, we have either cholinergic drugs or acetylcholinesterase inhibitors. Now, the theory behind it is the same of how they work. Here, they can increase drainage of intraocular fluid by widening the anterior chamber angle, and also it will increase the drainage of aqueous humor via the conventional route. And lastly, we have rho kinase norepinephrine plasma membrane dual inhibitors. Now, this drug was approved fairly recent in 2017. Now, this agent acts as both a rho kinase inhibitor and a norepinephrine transporter inhibitor. And in particular, this drug, Repressor, is a novel agent that specifically targets the conventional trabecular pathway of aqueous humor outflow and as a inhibitor to those two targets, as opposing to affecting other outflows route, just like those prostaglandin F2 agents. So remember that this agent, Repressor, work on the conventional route and not the accessory uveosacral outflow. All right, so that is a very quick review on glaucoma, its pathophysiology, and some of the drug classes that are used to treat this disease. Well, that is all for this quick review. Thank you very much for watching. I'll see you next time. Take care. Bye.